Welcome to 𝗲𝗵𝗴𝗿𝗺, my dear friends. This is Dr. 𝗲𝗵𝗴𝗺 and I'm your pediatric faculty. This is the class where we'll be discussing the very important topic, that's the endocardial cushion defect. Now we are in the 6th class 6th of our pediatric cardiology, and the topic of discussion is endocardial cushion defect or the AV septal defect. So if you know what is endocardial cushion, so in the previous video I think I've tried to show you when we were discussing the ASD. So this is your atria, this is your ventricle. I'm so sorry for the poor drawing, but then yeah. So this is, this is the for example, if this is the septum primum, okay, then there comes a hole that is called as foramen primum, and then here is the endocardial cushion. This is the endocardial cushion. Okay, so now what is endocardial cushion defect? So it's actually endocardial cushion defect means that the endocardial cushion is not getting formed properly, and the normal function of endocardial cushion is to form mainly three things. One is going to be the atrioventricular septum, other is going to be the atrioventricular valves, okay, and the other is going to be the actually two things only, atrioventricular septum and atrioventricular valves. So it's a group of congenital heart disease which involves the atrioventricular septum as well as the atrioventricular valves. Now, endocardial cushion defect is most commonly seen with the Down syndrome. This is extremely important, okay. So whenever they ask you what is the most common heart abnormality which occurs in the Down syndrome, this is going to be what? This is going to be your the endocardial cushion defect. How to remember? D and E coming together. So endocardial cushion defect in the Down syndrome, and it is also associated starting from the D only, that is diabetes. So if the mother is diabetic, there are high chances that the child is going to have what? That the child is going to have endocardial cushion defect. This is the way how you remember it, okay. So generally what happens is it is usually symptomatic by 6 weeks of the age, okay. By 6 weeks of the age it is symptomatic, and what will be the symptom? It's going to have a heart failure. It's going to have a heart failure. Now why there is heart failure? So see, the heart failure is going to occur because I'll show you first. Can you see this is the normal one, okay. This is a partial atrioventricular septal defect. Can you see this is a partial? There is no septal, the septum is developed, but there is a partial septum which has developed, and here can you see there is no septum which is developed, okay. So there is no septum which has actually developed between the right and the left side. So a lot of blood coming and going and coming and going from the left ventricle, from the right ventricle. They are also have to do a lot of work, okay. So that's why there are high oxygen demand from the ventricles, from the myocytes, and of course that leads to what? That leads to heart failure, okay. In this, actually what happens is, because a lot of blood is going to come from to the left side, okay. I'll show you, just look it into this box. This septum is not functional, okay. This septum is actually not functional. So a lot of blood is going to come from to the left side, then a lot of blood is going to go to the right side because the left side musculature is strong. So that's why there is a loud P2 which will be heard. There will be ejection murmur because the pulmonary blood flow is increased, okay. And because there is no separation which is present like this also, so there will be a lot of regurgitation which is going to occur from the ventricles to the atria. So there is a lot of atrioventricular valve regurgitation murmurs which are happening, okay. So as I've told you, left to right shunt is going to be there, increased pulmonary blood flow is going to be there, okay. So because there is increased volume, there is heart failure. And now what is happening? A lot of blood is going from the ventricles, especially because they are having a good musculature, strong musculature, rather than the atria, That's why atria is going to have a lot of blood, and this atria can go into the atrial fibrillation. And because a lot of blood was going to the pulmonary vessels, there is a pulmonary hypertension. And because there is a pulmonary hypertension, the pulmonary musculature is going to grow in the later stages. And what is going to happen? The blood will start going from the right side to the left side. Okay, in the end, this is called as Eisenmingerization, and this is actually a cyanotic heart disease. Why? Because a less amount of blood is going to the lungs. Again, in order to see any abnormality in the heart, echocardiography is the gold standard, which is going to show you the defect, and of course the common atrioventricular valve defect also. Chest X-ray is going to show cardiomegaly and increased pulmonary vascular markings. There is a left axis deviation which is going to occur. Left axis is deviated because of either the right ventricular hypertrophy or the left ventricular hypertrophy, but mostly the left ventricular hypertrophy is going to occur. Why? Because less amount of blood is going. Can you understand? Less amount of blood is exiting from your, it is going to exit from the aorta. So the left ventricular tries its level best, to increase the flow. Got it? Great. So what is the management? So you have to do the management of the heart failure, the diuretics, the ACE inhibitors, the digoxin. These are just the cardioprotective drugs. So you have to remember them. And surgical correction is also needed in some cases, just like the pulmonary vascular diseases is occurring. Now, what are the time of surgery? This is important. This is the atrioventricular septal defect or endocardial cushion defect. This is going to take 6 months. Okay. So I mean to say that you have to treat it after 6 months of the age, but if it is partial, then you have to do by 18 months. Okay, 18 months of the age. That means 1.5 year actually, and this is the 0.5 year. Okay, so if it's complete, just in when the child grows 0.5 years, you can do the surgery. But if it is partial, then you can wait for a longer period of time, like 1.5 years or something like that. Okay. So thank you so much, and the comment section is always yours for asking the doubt. God bless you. We'll see you in the next class.